Hi, Dr. Sonneville. Thank you for being here with us today. Can you tell us the story behind your passion for metabolic diseases and bariatric surgery?
Yes, thank you for the question. It was 12 years ago. I had the opportunity. I could visit a colleague who had a large practice in bariatric surgery, and that was the start of my career. We saw the beautiful results of the weight loss on the patients, and this reinforces my study activities and working capacity.
How affects obesity someone's body? What are the real risks related to obesity, and what are the overall expectations after weight loss?
As a matter of fact, obesity is a silent killer. It's dangerous to be obese. It affects your health and it affects also your life expectancy in a considerable way. So it is all levels of overweight and obesity should for the best be treated. People who lose a lot of weight have a better life expectancy. So I think if you can't lose your weight with physical exercises and with diet, and you're real obese, you have a BMI above 35 and especially above 40, I think the possibility of weight loss surgery should be asked.
For which type of patients overweight becomes really dangerous?
Yeah, when we look at lifetime expectancy tables from the insurance companies, we see that from BMI 35 on, you have a double relative risk for earlier death and having more diseases. So I think we can consider for people who are 32, 33, 34, 35 on, that weight loss surgery, if the classical therapies aren't successful, weight loss surgery should be taken in consideration.
So you saw hundreds of patients yet. Many people wonder, why does a normal diet not work? Is it morally accepted that someone has surgery to lose weight?
I think it's really morally unacceptable that obese people stay obese and that they have unsuccessful diets and so on. I think really that the problem is first of all on a big scale, on world scale and on scale of public health, is to avoid obesity. I think that's the most important message, to avoid it, to become never obese, to let the children never become very fat and overweighted. That's the first thing. But I think from the moment on you have young persons who are BMI 35, 40 on and more, that is morally unacceptable to leave those people so in overweight with a high risk for whatever, for diabetes, hypertension, osteoarthrosis, cardiac disease, depression, unemployment and so on. I think that's a bigger moral problem than to operate those patients in a safe setting, of course, and in a total system of support, with a program of psychologists and physical exercises.
What is really important for you as a surgeon before accepting a patient for any type of obesity surgery?
I think the people, it should be the choice of the person. They shouldn't be forced to do it. It should be their free choice to have obesity surgery in a total package, in a total support system, training system. And I think that's the most important. People should also be aware that the surgery is a part of the treatment. Beside, as I told before, beside healthy food intake, sufficient physical exercises and lifestyle modification. I think that's most important. Of course, I shouldn't be addicted to substance abuse, alcohol, drugs, real heavy food intake diseases should be treated before. People who have a too high BMI or too risky should be, before surgery, lose weight to avoid a too risky surgical treatment.
Okay.
For example, for 6 to 7 months before surgery, they should have training and food advice. So they lost before the surgery already a lot of weight.
Okay.
And in that way people have a low operative risk.
So there are general guidelines of the WHO.
That's right.
Can you tell us something more about these principles?
These principles are also the principles as described by the National Institute of Health in 1991, and are people who are BMI above 35 with comorbidities, as there are diabetes, hypertension, osteoarthritis, depression, sleep apnea, or people with a BMI above 40. Those people are accepted by WHO after, of course, attempts without surgery, with diet and with physical exercise. Those people can be accepted after psychological screening for obesity surgery.
Yeah. So what are the general risks related to the surgery?
We can divide those risks in two types of risks. You have the early risks and you have the late risks of the surgery, long-term problems. So at the time of surgery you can have bleeding, you can have leakage, and people can have also cardiovascular problems during the anesthesia, of course. We can tell that deep venous thrombosis and lung problems are very low. I think a lot of those problems are overestimated because people come after surgery to the emergency department or they see their GP and people think I have a lung problem, but as a matter of fact it is a problem of the surgery itself. It's a leak or it's an abscess formation or bleeding. So that's are the early risks, and late risks are the risks of metabolic losses, for example too low protein or calcium. So people should be followed very thoroughly by regular blood checkup to see if they take all their vitamins. Metabolic replacement therapy should be followed very thoroughly. Calcium, iron, zinc, and with a healthy food intake with sufficient proteins and vitamins. So and then I think that the risk at the long term is very low.
Okay. Do you have pre-op diet instructions? And what are the general guidelines and why are the pre-op instructions are important?
So we can divide the pre-op diet guidelines in two types. First of all, people who are really much overweight should follow a long-term, low-calorie diet during months to have a low operative risk. And people, on the other hand, people who have more the apple form aspect of obesity should follow a short-term, for example 2 weeks, low-calorie diet with high protein content to let the liver shrink down, to let the liver lose the glycogen storage amount. So the liver is smaller, so the surgery can be done much easier and recovery is much faster. So for conclusion, it is a low-calorie, high-protein diet during at least 2 weeks, and for certain people a few months.
Okay, so having weight loss surgery and not losing weight, is that possible? What is your experience with that?
So that's a good question, very good question. Indeed, weight loss surgery is not absolute, is not a guarantee for weight loss. We can see at the long term that 10 to 20% of the patients doesn't lose enough weight or gains weight again at a considerable level. That's a big issue and a big problem for the obesity treatment centers.
Now, what are the reasons for that?
So I think there are different reasons, of course. If people have no physical exercise afterwards, or they have not the right food intake despite a good surgical procedure, I think that's the reason. On the other hand, of course, there can also be some operative failures. So as we know, there can be a recanalization between the excluded stomach and the active little stomach, for example in a gastric bypass. So the old absorptive the pathway is again active. So that's going to be a reason. But I think the biggest reason is of course the failure of following a good diet and having sufficient physical exercises.
Okay.
You also have to know from which BMI on or from which mass on the people start with the weight loss. The higher the weight, the worse the results. The lower the weight or the lower the BMI, the better the results, also on long term.
Okay. So what is the average weight loss that someone can expect after surgery?
That's a weight loss. That's most of the time it's called excess body mass weight loss, and it can from 50% to 90% on, depending on, as I told before, the start BMI, the starting point, and also the type of surgery. If you have purely restrictive surgery, I think persons lose a little bit less weight than if you have also a malabsorptive component on the surgery.
What are the most common options in bariatric surgery?
The most common options, we can divide the surgery types on the intestines in two types. So first the restrictive surgery. When we have on the left side, on all the spectrum, we have the gastric band. Then a little bit much stronger is the sleeve gastrectomy, which is a tubulization of the stomach. If people don't want to have a resection of the stomach, you can have an imbrication sleeve system. That means that we suture on the stomach in different layers the outer side of the stomach, so we also create a tube. So these are the restrictive procedures. On the other hand, we have the malabsorptive procedures. With the strongest malabsorptive procedure is the Scopinaro procedure, which I almost never do, except in rare cases of redo surgery. And I think if you have a very high weight, I think the duodenal switch is a good option, so as malabsorptive procedure. And in between those two groups of surgery, so the malabsorptive surgeries and the restrictive surgery, we can place the gastric bypass as the golden standard between those two groups. And I think nowadays, since a few years, I think the Bilrod 2 gastric bypass has a good effect, is less operative risk, and gives you also a better quality of life compared to the roux-en-y gastric bypass, which is a bypass which was the gold standard until a few years ago, but gives for a lot of patients an embarrassing dumping syndrome. So I think that people should know the pro and the con of the different surgical types, so they can choose themselves which type of surgery, talking with a surgeon, and so they can choose the type of surgery with the surgeon between a band, a sleeve with resection or a sleeve with imbrication, a gastric bypass, or either a roux-en-y bypass or a Bilrod 2 bypass, or they can choose for a duodenal switch. If they really have a very high weight on one side, is the duodenal switch for people with very high weight, but then it will be done in two steps most of the time. First we do the sleeve gastrectomy part of the duodenal switch, and then we do the conversion of the small intestines. Or for people who want to really avoid dumping syndrome, I think duodenal switch is good.
Okay. Can we have a closer look at different types of surgery? Starting maybe with the first surgery, those procedures that restrict the amount of food which can be eaten. A popular type of weight loss surgery is the gastric band. In some simple words, what does the surgery involve?
Yeah, first we talk this now about the gastric band. This placement of an adjustable silicone ring, which has an inner little band connected to a tube, which is brought outside abdomen to the abdominal wall, and there is a little box through which the surgeon or the nurse can inject saline to fill up the inner band of the adjustable band. That way the band gives you a smaller transit zone of food at the upper part of the stomach. It is a laparoscopic placement and it is the less invasive surgery type for obesity. Of course, it has also its own drawbacks, but maybe we can talk about later on. So to conclude, it is an adjustable silicone ring at the upper part of your stomach by which the amount of food intake is restricted.
And what is the advantage? Why choosing for this type of surgery?
The advantage is that it is low operative risk, short operation time, and it is adjustable and it is easily reversible.
And the disadvantages?
The disadvantages is it is an implantation of a foreign material. It can cause also an erosion in the stomach. This means that the band cuts through the wall of the stomach and arrives inside the stomach instead of being around the stomach. Some people also create a little stomach above the ring, which is called a pouch dilation, or when it is a fast dilation, it's a slippage of the stomach above the ring, which causes obstruction and needs fast intervention. Another problem is that the tube can disconnect from the port, or there can be mechanical failure.
Who can be approved for this type of surgery?
People who are overweight, of course, who have obesity are approved. People who are afraid of having a really change in their intestines are approved for gastric band surgery.
How long does a patient stay in the hospital? What can a patient expect from the hospital stay?
People arrive at the hospital early in the morning, they receive the surgery during that day, they have a checkup at the end of the day or the next morning, and they can be discharged next day. So the stay is one overnight stay. Some people who are very young and have low operative risk can be done in day clinic, but that's exceptionally. I think it's safer to do it with one overnight stay.
What can a patient expect after surgery? How soon will an average patient recover?
So for the recovery time is very fast. People complain 1 or 2 days of some pain, moderate pain. They can be easily treated with standard painkillers. For lifting heavy weight, we advise people to wait 4 to 6 weeks. People who have administrative jobs can work after 1 week, 2 weeks.
And what about the aftercare? Which type of aftercare does a patient need, and how important is the following up in the overall success of the losing weight?
It's very important that people have a good support, and at the earliest time they have to wait 8 weeks to adjust the band. Also beside that, of course, physical exercises are very important. Choosing healthy food and taking healthy food is very important. It's very important that people are coached or supported regularly on long term. Otherwise, people should start eating bad foods maybe after too fast closure of the band. The amount of healthy food that can be eaten is too low, and people compensate by eating bad food, fat, sugar, cookies, chocolate, cream. That's very important that the band isn't adjusted too fast. Okay. If he's adjusted too fast, people compensate. A lot of people compensate with eating and drinking wrong food.
You also performed a gastric sleeve surgery and gastric plication surgery. What does the gastric sleeve surgery involve?
So the sleeve gastrectomy is a surgery by which the storage capacity of the stomach is diminished on a considerable way. This is done by a resection of the fundus and the corpse, the body of the stomach, alongside a tube, which we call a 34 French tube. This is about the thickness of a finger, that tube, and alongside that tube all the rest of the stomach is resected by using endoscopic stapler resection devices. That way people can only eat after that surgery a few spoons. They have to wait till that amount of food is gone through the pylorus. The same way happens when we do an imbrication sleeve, but then we don't resect the stomach, we just suture 3 to 4 layers on the stomach outer side, so that the inner side of the stomach becomes a small tube again. The advantage of this type of surgery is the fast procedure, low risk, and it's a procedure that is almost possible on every patient. By doing the sleeve gastrectomy, people, besides the restriction, also have a feeling of less appetite by reducing the amount of active ghrelin. So that's an advantage that we see after the sleeve gastrectomy. The ideal candidates for sleeve gastrectomy are, it's also personal choice of course by the patient, but I think people who really eat a lot, who have high volume intake of food, those people I think have a good success with weight loss. People who are grazing and eating little things all day through, those people haven't that much success with a sleeve gastrectomy.
Are there certain disadvantages or typical risk related to the sleeve gastrectomy?
Yes, people lose their stomach when it is a sleeve gastrectomy for 2/3. So we can't reverse that type of surgery. That's one problem or one disadvantage. Another disadvantage is that people, some complain of a little bit more gastroesophageal reflux, more acid reflux. That is typical for sleeve gastrectomy. And sometimes some stomach ache, which is not dangerous but can happen.
So the surgery is performed laparoscopically. What is the main advantage compared with classical open surgery?
All types of surgery that we are doing is done by laparoscopy. The main advantage is that people have faster recovery, have low risk of having incisional hernia. So I think that's the main advantage. Very fast recovery time, early ambulation. From the moment on the person arrives from the recovery room on the ward, they start walking around, which is almost impossible with open surgery. So I think for very heavy persons, I think it's really a big advantage.
So when can a patient return to his daily activity with this kind of procedure? Is it also day clinic or one night hospital stay?
Yeah, it's a one-night hospital stay for sleeve gastrectomy, 1 or 2 nights depending on the initial BMI, depending on the age of the persons, and starting their daily activities can be done for light work after a week. I think for heavy work 3 to 4 weeks. So it goes very fast.
Okay. So the next type of surgery is the gastric plication surgery. How different is the gastric sleeve hysterectomy and the gastric band surgery from the gastric plication?
Gastric plication surgery, I think it has the same effect. I haven't yet studies on that. I think it's the same effect of the classic sleeve gastrectomy, but it can be done at a lower cost because we don't need expensive staple material. The weight loss at the long term I think is the same. The advantages compared to the band is that we don't leave a foreign material inside. The sleeve on itself, is it the sleeve resection or is it the sleeve imbrication? It has a higher weight loss I think than the band and a longer effect. We can do it. Is less painful. The imbrication sleeve is less painful than the sleeve gastrectomy with resection.
When is this type of surgery preferred to the others?
That's a difficult question. I think it's a personal choice. Both three types of surgery has a very good effect for people who are really the volume eaters. I think people who want having good surgery with low cost, with good effect, I think the imbrication sleeve is an option. If they can spend a little more, then I think the sleeve gastrectomy is a good option. People who really want to have lowest cost surgery, I think then you only have to choose for the band surgery, I think. And all three types, especially for people who are volume eaters. And I think for super obese people, BMI above 60, I think that we opt for sleeve gastrectomy. Because I think that then the band is difficult first to place and has not sufficient effect, I think, for the super obese people. I think the first step for the treating those persons is a sleeve gastrectomy.
Okay, so in the second type of bariatric surgeries, there is a combination of food restriction with altering the digestive system. Can you tell us something more about this type of surgery? Why would the patient choose for this type of surgery?
Yeah, those type of surgery is called the biliopancreatic diversion, and it should be stressed upon that this is a general name. Most of people think it is a scopinaro, but also the other types of surgeries are biliopancreatic diversion surgeries. Those surgeries, besides restricting the amount of food by the sleeve or by doing a tubulization and a gastric bypass, also create a less amount of food that is absorbed by the small bowel, and more or lesser amount of absorption is created. This can be done either by a gastric bypass, a roux-en-y gastric bypass, but this type of bypass can have the dumping effect as a drawback, or this can be done by the mini gastric bypass, also called the Billroth 2 gastric bypass, which has less dumping effect and also is safer. By the way, there is only one anastomosis instead of two. The third option that is performed is the duodenal switch. At that type of surgery, there is a change of intestinal flow at the level of the duodenum. This surgery is of course the strongest weight loss surgery type, but it is also the most risky type of surgery. That's why we are doing this type of surgery nowadays in 2 steps, with 6 months to 1 year between the first step, the sleeve gastrectomy, and after 6 months to 1 year, the duodenal switch part.
So, for which type of obese patients profile, the roux-en-y bypass is a suitable option?
I think the roux-en-y bypass is a suitable option for the persons who have a real problem with gastroesophageal reflux. By doing the roux-en-y bypass, I think that can be avoided. For people who have no reflux problems, I think the Bilroad 2 bypass is a good option. For persons who are really very high weight, or people who doesn't want or will have wanted to have the lowest risk for dumping, I think they have to choose for a duodenal switch.
So can you tell us something more about the mini gastric bypass? What is different in this procedure?
The biggest difference for the mini gastric bypass is that it is the diversion surgery with the lowest operative risk. Because there's only one anastomosis, the biggest advantage is the lower chance of dumping compared to the roux-en-y gastric bypass, and it has also a good effect due to the moderate malabsorption. So it has an advantage compared to the duodenal switch because the malabsorption is not so strong as on the duodenal switch. So the risk of having a lack of vitamins and calcium and so on is lower than with the duodenal switch. And the advantage is the advantage of a gastric bypass, but it has no or a lower chance of dumping. The only drawback of the Bilroad 2 gastric bypass or mini gastric bypass specific is the biliary reflux. On a small amount of patients we have to convert the mini bypass to a standard roux-en-y bypass due to the biliary reflux that can happen in the little stomach.
So when is a duodenal switch considered?
The duodenal switch is considered for the very high BMI patients or people who have to take a lot of medication that can cause gastritis. Because on a duodenal switch you can still have the stomach which can be examined by the endoscopist on a regular way. When you have a gastric bypass and you have to take in medication, for example anti-inflammatory drugs or anti-coumadin preparation, and you can have a gastric bleeding, people who have those medications have better a duodenal switch or at least a sleeve. They shouldn't have a gastric bypass. People also with a high level of lipid in the blood, who have hypercholesterolemia, I think they can be served the best with a malabsorptive procedure, either a duodenal switch or either a mini gastric bypass. That's
okay.
But at the end, the patient decides which type of surgery after discussion with the surgeon. The patient decides which type of surgery he wants to have, of course.
What are the standard pre-op tests, and can you give us an example when extra pre-op testing is necessary?
The standard pre-op test consists about ECG and a laboratory test. For people with cardiac problems, they need also sonography of the heart and a test with a cardiologist. People who have lung problems should have a chest X-ray. Young persons with no problems, without problems on the lungs, doesn't need that. When you consider a gastric bypass surgery, we advise to have a gastroscopy on beforehand to check if there's no problem in the stomach. When you choose for sleeve gastrectomy, it is not bad to have a gastroscopy, but it's not really necessary when you have no gastric complaints on beforehand.
So what type of anesthesia is used?
Because it's a laparoscopic procedure, we always use general endotracheal anesthesia. We can't do this procedure with local anesthesia or with epidural anesthesia.
And why is that?
Because it's a laparoscopic procedure and the anesthesiologist can't stop all the pain when you do laparoscopy.
Okay.
When you do laparotomy, you can do it with epidural anesthesia. But most people have at this time in 2012 no problems with the general anesthesia. It's very safe.
Yeah, safe way to surgery. Some surgeons remove the gallbladder when doing a weight loss surgery. Why is this done? And do you do that also?
Why is that done? This is done because when you lose weight on a fast rhythm, especially with diversion surgery, the solubility of the gall fluid is less and the gall becomes thicker. There is crystallization and formation of gallbladder lithiases. So to prevent gallbladder stones and gallbladder infection, it is removed on beforehand. We adopt the strategy of leaving the gallbladder in place and giving the persons 6 months medication to avoid gallbladder sludge and stone formation. Of course, if people have pre-operative on the sonography gallbladder stones, we remove it. But we don't remove it standardly.
Okay.
Except if people have problems with follow-up later on, we can discuss on beforehand to remove the gallbladder. But we don't remove a healthy organ when there is no problem.
So, once a patient is approved for surgery, how long is the waiting time?
It is depending on the start BMI of the person, on his physical exercise capacity. People at least should have a time of consideration about 3 to 6 weeks. People who have a really high BMI, the waiting time can be months. As a matter of fact, it's not a waiting time. They start the treatment of obesity therapy by doing more exercise and eating healthy, so they don't wait, because they should know that the surgery on itself is not a treatment.
What are the most important diet rules before surgery? Why is it important to follow the guidelines?
It's very important before surgery that people eat a lot of vegetables, so they have a lot of amount of vitamins inside. A lot of those obese people have not a varied diet. They eat a lot of starch, a lot of fat, and they have a lack of vitamins, a lot of those persons. If they have then also a diversion surgery, they will really have too low vitamin amount. So it's very important first to lose the weight by eating a low calorie, high protein diet, but also to have enough vitamins on beforehand, and the iron storage should also be checked, especially for women who have a lot of iron loss every month with their periods. So I think a checkup before with lab is important, and eating a healthy diet before is also a test sometimes of motivation of the patient. Is he motivated or not, he or she? So it has different reasons, that the preoperative diet, different reasons why it is done. But the most important aim of this diet is the safety that we want to have at the time of surgery, of course. The lowest weight, the safer, and the less fat in the liver, the safer.
What are the most important diet changes after the surgery?
First of all, you have the frequency of the food intake will be more than before, and the amount of food intake will be, of course, much less than before. In the first weeks, it's also very important that the people have sufficient fluid intake to avoid renal calculi, renal stones, which can be quite embarrassing. And of course, a variety of food with all types of vegetables is important to have enough vitamin intake. Also the extra vitamin intake, calcium, iron, zinc is very important after surgery. So in the beginning, people will have to chew their food very thoroughly So it's a big difference. Most people don't complain about it. Some people have it a little bit difficult the first weeks.
So, and it's best for the patient to take nutritional supplements after the surgery?
It is not only the best, it is really necessary and mandatory to have vitamin intake and nutritional supplements, especially after the diversion surgery. We can, maybe after sleeve gastrectomy and gastric band, it isn't so important to have extra vitamins, but especially after the bypass and during a switch, people should take in lifelong their nutritional supplements and have regular blood checkup.
What about pregnancy after weight loss surgery? What are the guidelines?
We advise people to wait 1 to 2 years after the weight loss surgery to become pregnant. Why is that? Because the body of the woman should be again in stabilization phase, so that woman has enough vitamins, especially folic acid, in her body to have a healthy baby. But of course it's healthier to become pregnant when you're low weight than becoming pregnant or even to become pregnant. Some people can't be pregnant when they are so obese. But after surgery we advise 1 to 2 years waiting time.
To conclude, doctor, what is your message to the people who consider weight loss surgery?
I think people should think very thoroughly about it. First, which type of surgery they want to have. Secondly, have they done already diet and physical exercises before? If that is not sufficient, I think they shouldn't wait very long to consider weight loss surgery. They should study very thoroughly the surgeon who is doing it, his results, and then most of the people will tell afterwards, after a year, doctor, if I should have known it before, I would have done it much earlier. So I think that's a message, because this is a real bad disease, obesity. I think it should be treated very thoroughly. So that's my message. Thank you very much for the questions.
Thank you, doctor, for this conversation. I wish you all the luck.
Thank you.